Purohit is head of the department and director of Cardiology of Care Hospital, Hyderabad. We also have some distinguished panelists among us, Professor Badiur Zaman, Professor of Cardiology, National Heart Foundation. We have Professor Prabir Kumar. He's head of the Department of Cardiology, Chittagong Medical College. Professor Tamzid Ahmed, Evercare Hospital, Dhaka, and Dr. Mahbubur Rahman from Labid Hospital. We as a panelists, we also have MJ Azam, Professor of Cardiology, National Institute of Cardiovascular Disease, and Professor Esar Khan from Ibrahim Medical College. Now, we also have Professor Amol as our special guest today. May I now invite Professor Shadul Krishna Banerjee to say something and to introduce the whole academic session.
Good afternoon. Welcome everybody. My favorite teacher and the distinguished interventional cardiologist and mother of interventional cardiology, Professor Sufia Rahman, the chairman of this session, the panelist of the webinar, the moderator, and all the participants. And the speakers, we have two speakers today, a very, very distinguished speaker, Mr. Jamal and Bharat Purohit from India. Definitely, I hope the session will be a very, very enjoyable and fruitful session. And I think I should not waste any time more because we are already 15 minutes late. So I want to request the moderator to start the session. And again, I want to express my heartfelt gratitude to everyone for giving me the opportunity to say something at the starting of the webinar. Thank you very much.
Thank you, sir. Let us go to the program directly. Now, may I invite Professor Mir Jamaluddin to kindly deliver his talk.
Assalamu alaikum, my respected teacher, Professor Sufia Rahman, and other panelists, and my respected Dean, Faculty of Postgraduate Medicine, Professor Shadul Krishna Banerjee, Professor Chaudhary Mishkat Ahmed, Professor Mustafa Zaman, founder of Bangladesh Heart Cardiovascular Research Foundation, and all other panelists from National Heart Foundation and Research Institute, Professor Badiur Zaman, Professor Amal Kumar Chaudhary from National Institute of Cardiology, Cardiovascular Institute, and Professor Amal Kumar Chaudhary, and Professor and other panelists, Dr. Mahbubur Rahman, the young primary interventionist, meaning that we know whenever primary angioplasty, we feel Dr. Mahbub as because he is one of the pioneer of primary angioplasty. Thank you all of the panelists. I have the opportunity to present my paper in front of my teacher, so it's my great pleasure. And I was a bit thinking, how should I present this in front of my teacher, from whom I have learned from the day one of cardiology. Even then, I shall try to say about the topics, and now I start my topics.
ওনাদেরকে প্যানেলিস্ট করে দিন, প্যানেলিস্ট। হ্যাঁ,
Slide presentation. So, are you seeing my slide?
Yes, sir. It's totally visible. Sir, kindly turn on your video, sir. Kindly turn on your video. Yes, sir. It's totally visible and it's fine, sir.
Okay, thank you. My topics is how to do LM PCI, tips and tricks, guidelines, and practical experience. Practically, it's a vast topics, and that is why I have made it smaller so that I can finish it in time. LM disease incidence, approximately 5% of the patients undergoing coronary angiogram, more frequent in women, associated with three-vessel disease in approximately 50% of the cases, and left main stenosis treated only medically have a 3-year mortality rate of 50%. And to do LM PCI, we shall have to consider many things like anatomy of the left main and the involvement. Are you hearing?
Yes, we can. Yes,
Okay.
we can hear you.
Thank you, sir. Anatomy of the left main as well as the anatomy of proximal LAD and ostium of the LAD and ostium of the left circumflex. Position of the left main PCI in the guideline, left main bifurcation stenting, role of IVUS, FFR, OCT, and choice of guide catheter, choice of PTCA guide wire, pre-dilatation, choice of stent, and post-dilatation. Unprotected left main lesion located complex and its complexity mostly in distal left main, approximately 75% and approximately 23 or 24% ostium and body of the left main. Why left main lesion is important? Because it supplies 70% of the left ventricular cardiac mass. Severe left main disease will reduce flow to a large portion of the myocardium, and left main coronary artery bifurcation intimal atherosclerosis is accelerated primarily in area of low shear stress in the lateral wall close to the LAD, and bifurcation in around 80% distal left main stenosis. And what are the major studies we have in our hand? Excel and Nobel. And left main disease, there is a heart team approach, and we have to heart team discussion, two very different procedures, but one in PCI, one arm is the PCI and another arm is CABG. In PCI arm, early advantage, and CABG arm, late advantage is more. And Excel trial, a prospective randomized trial comparing everolimus eluting stents and bypass graft surgery in selected patients with left main coronary artery lesion and PCI, and treatment of patients with left main coronary artery disease and low or intermediate syntax score with cobalt chromium everolimus eluting stent resulted in similar rates of the primary endpoint of death, stroke, or MI at 3 years, with fewer adverse events within 30 days compared to CABG. And recent published Excel data up to 5 years, it is almost equal. PCI may thus be considered an acceptable or even preferred revascularization modality for selected patients with left main coronary artery disease, a decision which should be made after heart team discussion, taking into account each patient's individual circumstances and preferences. Here we can see all-cause death, stroke, and MI of Excel trial in for 5 years. It is almost equal to CABG. CABG 19.2% and PCI is 22%, which is not a statistically significant difference. And Nobel trial, Percutaneous coronary angioplasty versus coronary artery bypass grafting in treatment of unprotected left main stenosis. And this Nobel trial showed that PCI with biodegradable polymer drug-eluting stent is inferior to CABG for clinical outcomes at 5 years following revascularization of unprotected left main disease. That is non-inferior. The hazard is highest with CABG in the first 30 days, with better outcomes with PCI between 30 days and 5 years. Outcomes were inferior with PCI compared with CABG, the Nobel comment. Position of the left main PCI in guide. We know the syntax score up to 22, class 1 both for CABG as well as PCI, and 23 to 32, class 1 CABG and class 2A PCI, and left main disease with high syntax score more than equal to or more than 33. It is class 1 indication for CABG and class 3 for PCI. Functional role of FFR and IVUS. Functional angioplasty, integrated use of FFR and IVUS. Avoid unnecessary PCI, avoid unnecessary surgery, minimize major adverse cardiac events, maximize clinical outcomes, save money, and save lives. Why FFR is essential? Angiography is not always enough. FFR is the only matched index with objective ischemia even in the left main disease and assessment of ischemia in left main and side branch. Why IVUS? Lesion assessment, treat or not to treat, and selection of the PCI technique, selection of appropriate device, procedural optimization, assessment of drug-eluting stent failures. And guidelines in recommendation, IVUS should be considered to assess the severity of unprotected left main lesion, class 2A indication, and IVUS should be considered to optimize treatment of unprotected left main lesion. This is also class 2A indication. And IVUS guidance saves lives in LM PCI. Here there is seen that significant difference of IVUS guided angioplasty and only angiography guided angioplasty. Angiographic lesion, where there is when we think that it is 30 to 60% stenosis, then we shall have to think MLA if less than 4.5 square millimeter, revascularize directly, and MLA if it is 4.5 and 6 millimeter square millimeter for LM, it is the gray zone, and MLA for more than 6 millimeter, we should avoid PCI. But 4.5 to 6 millimeter square millimeter, then we should do FFR or non-invasive stress test, consider body size, age, plaque burden, and remodeling, and do according. Guide catheter selection, preferably Uddin's left, 7 French, even maybe 8 French, and extra backup guide if distal bifurcation, and if ostial or proximal LM lesion, then Uddin's left is preferable. And the route, both transradial as well as transfemoral, is possible for left main PCI, as because we can use 6 French or 7 French both by transradial procedure, and by femoral approach we can also use 8 French if there is trifurcation or bifurcation lesions. Guide wire selection, preferably floppy or extra support wire, both LED. We should wear both LED and left circumflex. And lesion preparation should never direct stenting. Adequate pre-dilatation should be done, and if calcified, rotablation may be necessary sometimes. Choice of stent. There are various theories in choosing the stent of in using in the left main. That it should be a drug-eluting stent, preferably 2nd generation or 3rd generation days. Nowadays, bioresorbable scaffold is also used. Stent should be deployed at 1:1. And regarding the design of the stent, open cell, all the open cell stent, now stents are open cell, out of which Resolute Onyx. Onyx has preferably better, some authority wants to say, because the side vessel access is very nice, and opening of the side branch is oval shaped, and it becomes almost 4.5 square millimeter, and so Onyx can be used. Some authority likes it. And post-dilatation. Post-dilatation should be done with NC balloon if required, kissing balloon inflation for distal bifurcation. And let us see some cases. Mr. X, a 55-year-old, non-hypertensive, non-diabetic smoker, and foreign service holder hailing from Kumilla, was admitted into an ICU plastic infarction, and PCI was done to RCA, and CABG was advised. And we see this is the scenario: distal left main involving the ostium of the LAD and ramus intermedius or early OM. And by transradial approach with 7 French guide, we have started the procedure, and angioplasty, we have wired both the ramus intermedius as well as LAD, and we are deploying on a stent into the ramus intermedius or high OM, and then we should do crossover stenting from LM to LAD. Stent is stent deployment. Stent deployment is in progress. And post dilatation with larger sizes balloon and high pressure, it is done. And this is the result after post dilatation. And this is the crossover technique or single stent strategy. And sometimes we need double stent strategy. This young man of 50 years, hypertensive and diabetic, having effort angina on minimal exertion and history of unstable angina, hospital admission, and then ECG sinus rhythm, and angiography shows RCA normal and left main, distal left main involving the ostium of the LAD and LCX. Here one thing we should say that left circumflex is almost more than dia is more than a left anterior descending, and we have done it transradial approach, and 6 in 7 sheath is used. And let us see. Both the LAD and LCX is pre-dilated, and after pre-dilatation, stent is positioned in the LM to LAD, and the balloon is kept into the LAD, and then left main to LCX stent deployment is in progress. It is 4.5 into 12, and balloon kept in the LM to LAD, it is 3.5. And by this balloon we have crushed. This is the first crush, and then recross. Before first crushing, we have withdrawn all the balloon and wire from the left circumflex, and then we reintroduced the wire into the left circumflex, and this is the first kiss. Now the LM to again all the wire and balloon is withdrawn from the left circumflex, and LM to LAD stent LM to LAD stent deployment is in progress. LM to LAD stent and deployment is done, and then pre-dilatation of the post-dilatation or port is done into the ostium of the left main, and then once again recrossed into the left circumflex, and after recrossing left circumflex and placing another balloon into the LAD to LM, and final kissing is done. And after final kissing on the right panel, report is done. And this is the result after report. This is the final result. And IVUS was done, but on IVUS CNA I have not preserved, and that is why I am unable to show. And this is professional stenting with TAP. This you see 100% occlusion of the left anterior descending artery, and so we decided to do LAD PCI. But whenever guide engaged into the left main, and there is dissection into the left main, and so seeing this dissection, we have introduced two wires one into the left circumflex, one into the left antero-descending. And we have deployed one stent from LM to LED, and after deployment of the stent from LM to LED, we have seen that dissection has progressed also into the left circumflex. And so we have decided to do a tap into the left circumflex. This stent is placing, and this is after deployment of the stent, final kissing of the left circumflex and LM to LED. And here also report was done. 55 years old male patient admitted with chronic stable angina with diabetic and hypertensive and echo around 58% left ventricular ejection fraction. Patient admitted for PCI having CAG done 1 week back. The left panel is transfemoral approach from a different center. They have shown the ostium, from ostium to entire left main is diseased. But we checked it in the doing for angioplasty, and we have found that body is almost all right. Only ostium is diseased, and so we have done IVUS. And IVUS showed that only ostium is significantly narrowed. Only ostium is significantly narrowed. And so we have done PCI to only LM. LED ostium was also significantly diseased, and that is why we have done crossover LM to LED. And what was done, and this is after IVUS. Approximate LED is 4.5 and square millimeter. 4.25 LED, 4.5 left main. This is the final result after angioplasty. This is another patient. Angiographic views is not shown. Here there is a angle is approximately 30 degree between LM, LED and LCX, and so we have decided to do a Culotte, and before it we have done IVUS to see the ostium of the left circumflex. Distal left main, it is approximately 5.94, and ostial LCX approximately 3.46, and ostial LED 3.85. So we redilated both the ostium of the LED and LCX. LM to LED stent is positioning now, and on the right panel, LM to LED deployment is in progress. This is the result after LM to LED. Now through the stent start, we have crossed the wire into the LED, and we have crossed a balloon. And this is the LM to LED stent deployment is in progress. And we have recrossed the left circumflex. Opening up of the start of the LCX, as well as post dilatation with kissing balloon angioplasty. Final kissing balloon angioplasty is done, and report is done. And this is the result after the final angioplasty, distal LM 4.67, ostial LCX 3.53, and ostial LAD 3.40. And further post dilatation done. And after this post dilatation, this is the result. And BS stenting, though is usually nowadays we do not accept BS stenting, but sometimes we may require when there is hurry, patient is in shock, or patient having unstable, and in that case we can do. This is the case where we have done simultaneous SKS, simultaneous kissing stenting. And the result after kissing balloon, disturbing, sorry. This is the result after SKS done. Take home message, nothing is complete alone. We still need an integrated approach with clinical manifestation, angiography, IVUS, and OCT in making our decision for unprotected left main stenosis. In left main disease involving both branches, stent technique should depend on individual patients' anatomical characteristics and operator's skill, but a provisional strategy may be effective. Left main PCI should be done by an experienced and appropriately equipped PCI team. Yesterday we have learned that in our National Heart Foundation and Research Institute, they have done approximately 2,100 left main PCI. And IVUS guidance in left main PCI is needed for lesion severity assessment, stenting strategy, selection of appropriate device, and stent sizing, moreover minimize maze. These slides are taken from a big slides, that is I had 148 slides, out of which cut paste done, and that is why the angle of the left distal left main and ostial involvement of the left LAD, ostial involvement of the LCX, angle between these two, and regarding the plug between these two is omitted. So I like to tell one thing: if there is angle is less than 70 degree, then Culotte or mostly Culotte we would do, or decay crash we can do. But if the angle is more than 70 degree, then we can do tap easily, or we can also do a mini crash. Thank you all. Thank you for patience here.
Thank you very much. Thank you very much for your excellent presentation, Professor Mir Jamal. Left main is the last frontier for the interventionist, and you have presented your case in such a lucid way, such a simple way, and you have covered all the method of doing the bifurcation lesion. The most difficult part of interventional cardiology. Now I will invite Professor Mustafa Zaman, who is the course director and the president of Bangladesh Cardiovascular Research, to have some comment on Professor Mir Jamal's presentation. And also I would like to invite Professor Sabina Hashim, Professor Khandakar Kamrul sir, and Professor Dr. Ashok Dutta, and probably Professor Saidur Rahman is also with us, and we are happy to have you as panelists with us. Professor SM Zaman.
Thank you, Professor Mishkat Ahmed, our teacher. Actually, I'm very happy for introducing me, and actually we are grateful, and my honest and sincere heartfelt gratitude to all, from Professor Sufia Rahman, Emeritus Professor, and especially she is actually pioneer interventional cardiologist of Bangladesh, and mother of interventional cardiology, and former professor cum director in ICVT. And we have Professor Shajal Banerjee, actually not only our teachers, just like our father, actually, we respect them. He actually encouraged all of our work. And Professor Mir Jamal Chaudhary already has presented nicely his lecture. And especially the next topic already, our friend from India, will lecture Bharat Vijay Purohit, Director and HOD, Head of Development Cardiology Care Hospital from Hyderabad. And his topic is very interesting, PCI complication. What is the myth or fact? How should we approach? And along with this, our long list of panelists, very, very learned person from Bangladesh, all are, especially I am mentioning Professor M. Bodiuজ্জামান from National Heart Foundation, Professor Tamjid Ahmed, Evercare Hospital, Professor Esar Khan, Professor from Ibrahim Cardiac Center Hospital, Professor Probir Kumar Das from Chittagong Medical College, Dr. Mahabur Rahman, Labid Hospital, already Dr. Mir Jamal, Professor Mir Jamal Chaudhary, introducing him nicely, Professor Mir Jamal Uddin. And our two presenters actually, they will present case for Dr. Abu Selim, our Associate Professor of BSMMU, and Dr. AKM Monwarul Islam, Associate Professor of NICVT. And our moderator, Chaudhary Mishkat Ahmed, actually is very learned person. Everybody knows about him. And a lot of renowned interventional cardiologists and clinical cardiologists already joining with us. Actually, I'm really happy to receive all of our panelists and our experts. Hope in this pandemic period will actually increase our learning curve in this process, by this process. So thank you again all. I'll not actually elaborate. I would request our next speaker, Dr. Bharat Vijay Purohit. Please present your case, and after that presentation, we'll discuss by our panelists. Thank you.
Thank you, Dr. Jamal, for this lucid introduction. And first of all, greetings from India. And I wish in these COVID times everybody is safe, and it is a nice way to connect and through these webinars. And it's very good that we learn from each other and understand. And the cases presented by Professor Jamal was really excellent. And in the outset, I would like to thank all the people who have invited me to present my talk here, especially Dr. Sophia, who is so revered, and I heard a lot about her, and then especially Professor Jamal, and then Dr. Mustafa and Dr. Azam, who spoke to me in the initial stage. Now, the topic which has been given to me is basically PCI complication. So I'll just share my screen. Let me, I hope you are able to see my screen. Is my screen visible?
Yes.
Yes, you may.
Yeah. So the topic which has been given is PCI complication. What is myth or fact, and how do we approach? So the complications in PCI, it can happen at any stage. We all know it, right? Because each step, starting from patient selection and to the final part and shifting the patient back. Before I start, I will just tell you, once I was doing a very complex angioplasty, and at the end of the 2-hour procedure, the procedure was successful, and then I was just trying to check my hemodynamics, and I found that the blood pressure was really on the lower side, around 60 or 70. I was a little confused why the blood pressure is low. So that procedure, I asked my technician to zero the connections, and instead of, while he was zeroing the connection, I said, okay, I will flush. So instead of me flushing, the technician flushed it, and there was some air bubble in the tubing, in the tubing which was connecting the pressure line, and unfortunately those air bubbles went into the coronary. And after 2 hours of successful procedure, this huge amount of air bubble which went from the tubing, the patient immediately crashed and we just could not save the patient. So the complications, they come unexpected. Even 1 second of our attention, if we lose, we'll end up in complication after doing such a successful procedure. If you're not careful at the end also, the complication can come. So starting from the access till you finish the procedure, we all have to be very attentive and make sure that complications do not develop to the patient. We should not be time. Now that with this little bit of personal experience, there is no specific way by which you can handle this complication. The most important way of handling complication is how your instincts work at that point of time, because the complication do not tell you, they do not fit into any specific pattern. At that point of time, how your mind works and how you have experienced in this last few years of intervention cardiology, those things will come in picture, and you will have your own innovative way of handling those complications. The myth is, if somebody says that I have been doing PCI but I never had any complication, I think that is the biggest myth. Anybody who has been doing PCI, he must have experienced some complication or the other. The fact is, if you do have PCI, you are bound to have complication one day or other. So, but important is not to get worried about the complication. What is more important is you should find out why the complication happened and what best you can do to prevent that complication. So what matters is not having a complication, but to able to predict it and take precaution and to able to handle those complications so that you can avoid morbidity and mortality. The statistics say every patient who has undergone a PCI, if you take the statistic, almost 10 to 15% of our PCI are associated with some complication. It may be major, it may be minor. Even a simple allergic reaction, that is also taken as a complication. So almost 15% of our PCIs do come with complication. And interesting statistics which I came across, which was published in 2017 in JACC, and it showed that the higher the experience, the higher the volume of the hospital as well as the operator. Hospital wise, we have classified it 400 to 800, more than 800. And as per the operator experience, we call somebody is doing at least 75 PCI in a year or more than 100. So based on that, they have said, and what they found is that almost 1.6% of patients can have complication if you are a low volume operator. And if you are a high volume operator, it comes to below that. And there is a difference of relative risk increase in 16% mortality between the operator who is low volume compared to the operator which is high volume. And if somebody has undergone a complication which is major, then there is a very, very high mortality in the near future, almost 10 to 15%, and almost 20 to 25% over a year. These people can develop mortality if major complications in these patients. So this is a simple algorithm which I was telling you in the beginning. Complication is suspected, you have 60-second time to decide. If you are able to think, yes, you think, ask for help, and you start acting. You must find out what the differential diagnosis, what are the reversible causes, what is the next step you can do, whom you want to call, enhance your cardiac performance, stabilize the BP and the rhythm of the patient, and try your level best to reverse the complication. That should be our motto when we are faced with a complication. If you don't have 60-second time, then you must have to act immediately, because if you are landing up in major issues, then you don't even have 60 seconds time. So what you have to do is you have to act. What you have to act, that is what you need to think, and immediately you ask. Important here is to improve the cardiac performance, stabilize the BP and the rhythm, make sure that you try to reverse the complication. What are the differential diagnoses which led to all these things, and then subsequently you stabilize the patient, and then subsequently you proceed with the procedure. Now, whether you want to proceed with the treatment at the same sitting, or you can continue optimal post-procedure support, pharmacology monitoring, and subsequently plan for a follow-up treatment. So this is how we need to act when we are faced with a complication. Instead of taking you deep into individual complication, because each and every complication will take a lot of time. So I'll be presenting few cases, and these are the various complications which we come across. The vascular complications are the most common. The access site bleeding, yes, of course, by changing from femoral to radial, because now that 90% of our procedures we are doing through radial. If it is a diagnostic, it is almost 99% of diagnostics we are doing through radial. Unless it's a post-bypass patient, we go for femoral. Invariably, we go with a radial approach. And one small personal experience I will say is, we always tend to check whether the ulnar and radial pulses are good or not. And but I have been doing PCI for almost 20 years, and except for the initial 2 or 3 years, I have never done testing whether the ulnar is patent or not patent. We don't do those tests. We just straight away go ahead, and by God's grace, nothing has happened till now, I think, by this time. So yes, of course, if you want to be more sure, you can go ahead and do the test, but it's not mandatory. You can still go ahead and do your radial PCI. Only problem is many times you face loop, and these loops are invariably bilateral. So if you still want to do, if you have a loop on the right side, I will suggest go with the ulnar approach on the left side. That will make your procedure much simpler rather than going from radial on the other side also. And because of radial procedure, the bleeding risks have come down, the retroperitoneal bleedings have come down. But when you do radial, then you are more likely to have occlusions. Almost 6 to 7% radial arteries get occluded. And if there is some perforation or some oozing has happened, then you may land up in compartment syndrome also. If you are doing procedure from the leg, there is a risk of atheroembolism. And if you are using it, then they are also having their own issues. When you do an angioplasty, these are the various complications we have come across. Failure to deploy the stent, either we are not able to reach because of tortuosity, calcification, or some other reason, or when you try to push and pull, the stent may get dislodged. And even if you have reached the place, the stent may not expand, or there may be fracture of the stent if you go with a high pressure. And if you are not deployed the stent properly, then you are likely to get a stent thrombosis. And extremely rarely we can get a stent infection. Restenosis, whether I call it a complication, is the limitation of technology. So I do not practically feel that restenosis is a complication. If you have the dissections, intramural hepatoma, the perforation of the artery, distal embolization like slow flow or no reflow, there may be air embolism, there may be major side branch occlusion, and which may give rise to significant ischemia or mitral infarction, or many times we have to send the patient for bypass, or if there is a failed PCI. If you are using O wire or O guiding, then there is a possibility that the wire may get entrapped, or there may be device-related complications like if you are using a rota or guide extension, which can cause dissection, or an IVUS, which may give rise to all these issues may need a. If many a times people have used balloons and they have found that the balloon have not deflated, and the patient has landed up in major issue, and then they have to try and puncture the balloon, or if not possible, then they have to send the patient for a bypass also. Some of the miscellaneous complications, we all know about contrast-induced nephropathy, the allergic reaction, which used to be very common in past when we were using ionic, but nowadays because of low osmolar or isoosmolar contrast, those issues have come down. Anticoagulation related, either when you give heparin, you may end up, or GP2B3A, that may lead to a higher hemorrhagic chances, or if the ACT is not proper thrombotic, and because of the use of heparin or GP2B3A, there may be a drop in platelet count, which may cause trouble subsequently, and infection. And if you are doing a prolonged procedure, there is a chance of radiation exposure and all these things. So if you see each of these topics, they require a separate discussion. So there were various codes which have been proposed to predict all these things, but I'll not go into the detail. And last but not the least, the coronary perforation, they are the most devastating complication. Nowadays we are seeing, because we are trying to tackle more of CTOs, calcific vessel, and we are using more of these taper tip wires and for proper deployment, we go with high pressure, or if you use rota, all these things lead to perforation. These are the Ellis et al. Had given this classification 1, 2, 3, 4, 5, and out of this 1 and 4 are really not very dangerous, because 1 is very minimal ventricle. If perforation is in ventricle, then you don't have to worry. 2 and 3 are the real problematic, and 3 is the most dangerous one. And if you are not careful, then the way to tackle type 2 and 3 is you go with a prolonged balloon, reverse heparin, you may do pericardial synthesis, or use a coronary covered stent, and if still not working, then go with the surgery. So I'll just show some of the slides, some of the complications which first one, as I told you, regarding we were discussing about the perforation. So this was a this is a 60-year-old gentleman, diabetic, hypertensive for 4 years. He had angina, and angio showed there was a total occlusion of the LCX after the OM1, and the RCA was also total occluded. LAD was normal. He had a viable myocardium in LCX and RCA territory, so we decided to go. This is the angiography. You can see here the LCX is completely occluded after the OM1. There are the 2 vessels, and the RCA in the mid part is also completely occluded. You can see some distal formation because of some collateral which are there. So initially, this procedure was done long back. At that time, we didn't have much CTO wires. The most important wire which we used to use at that time was the Shinobi wire, Shinobi Plus. All those who have been doing intervention long back, nowadays it is not available. So this was the circumflex angioplasty. You can see we crossed easily, and we put a stent, and we got a excellent result here. You can see. So this was not the problem. The problem came when we started dealing with the RCA. This is how the RCA happened. We were trying to, I think, some issue with the media. So this was a wire. It was the Shinobi Plus wire. We tried to cross the wire, and you can see here the wire has crossed. So which we thought was probably in the lumen, and then we tried to dilate. There's a small dot, 1.25 millimeter balloon, and then after there was a little bit of staining here. You can see some black thing because the media is not playing, so you're not able to see. And then we deployed this stent here, which was a 2.5 into 15 millimeter stent. And then what we saw was the moment we deployed the stent, there was a massive perforation, and patient immediately started collapsing on the table itself. Immediately we did a pericardial synthesis, and you can see this massive perforation here. It was a really horrible sight to look at. And now, what are the options we have? Because we are not sure whether the wire went into the true lumen distally. So how do we deploy a cover stent here? That was the major challenge, because of CTO, and we have already deployed one stent. Now, if I think of putting a cover stent here, maybe that will again aggravate the whole thing. So we were just thinking what to do, and then we came up with a different idea. What we decided was, because we decided to seal off the whole perforation by injecting a isoamyl-2 cyanoacrylate bioadhesive surgical glue. This is a glue basically used by the surgeons and others to control the bleeding in that place. So what we did is we diluted it with lipiodol, and we injected it, because the problem with this glue is it is very sticky. The moment it comes in contact with blood, immediately it will stuck. So if your wire or guiding catheter or anything is there, it will get stuck into the wall, and you will not be able to pull it out. So the whole idea is you inject it and then immediately take out the, and at the same time you should not inject in the aorta or any other place. So that much of coordination is required. So what we did is we took a over the wire balloon. we inflated the balloon in the beginning part, and this is how the glue is available in India. I'm not sure whether such thing this is available there or not. So you can see here we had inflated with the presence of an over the wire balloon. We inflated here, and we prepared. And now you can see the lipiodol dilated with the glue is being injected. You can see it is coming out a little bit, and then with that, this whole thing got sealed up, and so the whole thing got sealed off, and finally we got a result which was almost similar to that of what we had in the past.
Hello.
You can see the RCA was completely occluded, and when we checked with the distal flow, the retrograde flow was still filling the distal part. The patient stabilized, and we shifted the patient. The LV function was still preserved. Nothing happened, and patient still continues to have angina, but we are trying to manage him with optimal medical management, and it's almost 7 years. Patient is still doing well. So this was one case where we came up with a novel idea of injecting a glue, because there was no other way we could have handled this. Now there is another very common complication we come across is when we are not careful with our guiding catheter. So this was a gentleman, 63-year-old, who had a chest pain. ECG was of inflammatory TMI. He had no comorbidity. She was taken up for an angiography. And if you see here, the access from the radial was pretty tortuous and lesion. So I thought everything will be very smooth, and we went to the left side. I was unable to hook the left side with the TIG catheter. I was not able to get good shot because I was worried whether there is osteal LCX or not, and what is the status in this area. So the idea was that what we did is we changed the catheter from diagnostic to a guiding. But you can see how the guiding is sitting. The moment I took a first shot, you can see there's a massive dissection which is going from left main into the LAD. And this was a 5 French guiding, because we had taken a 5 French sheet, so nothing could have been done with this. So immediately you can see here the OM looks pretty normal. The LAD dissection is very bad dissection. The LMC has started closing. The patient started complaining of severe pain, and the BP started dropping. And the BP had come down to 70 or 80. So you can see the bad dissection starting from left main, going into the diagonal, going to the LAD, and the LAD is almost closing down here. So immediately here at all. And I changed from radial to femoral because I had to use a 7 French sheet, and this was a 5 French. So this was the dye staining which was there. Now these are the classification of different types of dissection. So the first thing which I did was, you can see here the guiding catheter from the radial was more looking upward. So probably the dissection happened from the up and went up. So here you can see my guiding catheter is looking a little downward. And then the first thing which I did, the moment wire went into the ramus, so or you can say first OM, so I secured the circumflex here, and then took another wire and wanted to check whether I'm in the true lumen or not, because it was a very bad dissection. The wire could have easily gone into this. So because the flow was not going down, I just tried to test here with the help of a balloon. The issue was, if my wire had gone from the LAD to a false track, and if I deploy a stent in the left vein, what it will do is it will seal off the circumflex. The flap would have closed the entire circumflex. So I had to make sure that I am in the true lumen here. And at that point of time, we didn't have the IVUS. So I came up with the idea that why not use a microcatheter and check distally and see whether we are in true or false lumen. So I took a third wire and went into the diagonal, because the common teaching is if your wires are going into the side branches, probably you are in the true lumen. So when my wire went smoothly, I thought maybe I'm in true lumen, and I injected through this. Very gently I injected through this, but I found that the wire was again in the false track. So there was no way I could have. You can see the wire in fault track, and there is hardly any flow going distally. Probably I was not in the true lumen, so I had to withdraw this wire and then try to remanipulate the whole thing back into the LAT. So you see, I have withdrawn the wire, and now I'm trying to change the track and trying to go into the LAD again. And after that, I went distally and found that right now I'm in the true lumen. So that the moment I found that I'm in the true lumen, I was pretty happy, and this was the 2.7532 DES and distally deployed, and then we used a 4.5 4 into I think 28 or 32 DES we used. And the moment we deployed the left main stent, there was a tight stenosis which was seen in the ostial LCX. So then it became very easy. It was almost like a T stenting. We did it, and we crossed with the wire and then dilated the sturts, and then we took a 3.5 to 13 DES, and then this is the final kiss we have here, and then the result was quite good. And subsequently, the patient stabilized. The moment we had a stent in the left main, the patient chest pain, everything had settled down, and then we did the stenting of the RCA, which was quite easy, not a very complicated issue. So this is how, at that point of time, we decided to go ahead and tackle the left main dissection without panicking much. And this is another common complication which we see, which is this was a 54-year male, non-diabetic, hypertension. He was a smoker. He had an old anterior MI, and I think it was 3-4 years back before when he came to us. So, and he had a recent angina of 6 months. Ejection fraction was 40% with the RW in LAD. And when we did an angio, we found there was a very critical lesion in LAD and circumflex. So probably the LAD lesion was old because he had an anterior MI, and he had recent angina because of the critical lesion in the distal LCX. You can see here. You can see this distal part of the LCX just before the bifurcation is very critically narrowed. So we decided to go ahead, and when we were committed to do an angioplasty, we decided, okay, let us finish the angioplasty of both circumflex as well as this. And circumflex angioplasty, the wire has crossed, and we took a 3.530, and then this was the result of the DES. Looks pretty good. And then we took a, I think it was a Galileo wire with the help of a balloon. We were trying to cross, but the wire was, if you see here, the wire had gone in the false lumen, that was not crossing. So we took a miracle wire, and the time when we were doing this procedure, we didn't have the Gaia wires. I think the miracle was the wire which was available at that time. So this wire was in a false track, so we had to change the track. Now, after changing the track, we can see the wire has nicely crossed into the true lumen. And the moment this happened, I was very happy. Okay, the major part is done. We dilated with the 2mm balloon proximally and distally, and then my focus was entirely on how the result looks. Now, if you see here, the flow has started, but when this was happening, suddenly I was just looking at this angio, and suddenly I realized that there is some bit of haziness which is seen in the circumflex. I hope you are all able to appreciate that. So we took a different view, and we found that there is a big clot which is formed in the ostium of the circumflex going into the left main origin. So that the moment we saw this, it became very imperative that because this is a dominant circumflex, so we had to, and there was a large OM here, so we had to protect both of them. So we first put a wire there, and then we put a wire in the OM. And by this time, you can see the thrombus has already migrated to the ostium of the LAD or in the distal left main. So what are the options which we have at this point of time? Well, how do we handle this kind of a thrombus? So there are different ways by which people handle the thrombus, because it's a fresh thrombus. Some people can use an aspiration device and aspirate this thrombus, and some, if it is still not working out, then we can always go ahead and plaster the thrombus in the side wall by putting 2 stents. But what we decided was, why not try with giving a thrombolytic to this patient, because the patient is still hemodynamically stable. It was still giving us some time. I just remember that algorithm. We had decided that if the patient is hemodynamically stable, you can start thinking of different ways. There's no need to panic and do certain things. Because if I put a stent here, then it will end up like almost like a trifurcation stenting. So immediately it may help us, but long term again we may have trouble in this patient. So we gave half dose of thrombolytic intracoronary, and once we gave half dose of thrombolytic, the thrombus has started clearing, and we had taken out the wire in the LED because LED was anyway CTO, so there was no point in keeping the wire there at this point of time. And now you can see once thrombolytic has been given, this thrombus in the left main has completely cleared off, and a little bit of thrombus, maybe some distal embolization had happened with the OM, but this was a too distal clot, so we didn't bother too much of aspirating and all this thing. So we waited for some more time just to see how things are happening. We checked the ACT was normal, and we took a diagnostic shot here, because once the thrombus had cleared from the left main, we took out the wire and everything, because any foreign material again is going to be a source of thrombus again. So once we found there is almost clearing of the thrombus from the left main and LCX, we decided to go ahead and finish the procedure again, and we crossed with the same miracle wire. And then this was a 3 into I think 33 millimeter stent in the LED, and yes, this was a 3 into 33 millimeter drug-eluting stent in the LED, and we had already deployed a 0.5 there. We got a very good result here, and patient stabilized. You can see there is no pinching of circumflex. It was just it was a huge LMCA, so it accommodated the left main stent here nicely without pinching the early OM or the ramus and the circumflex, and we got a good result. So I think I should stop here, because complications, whatever I have mentioned in my career of almost 20 years, I think I must have seen almost all those complications which I mentioned there, starting from access site bleeding to complications related to the closure device, to contrast, to stroke, CVAs, and all those things. So it's just a matter of being more careful what we are doing, and sometimes things happen without your understanding. In this patient, the ACT, when the thrombus was detected, was almost 320, but still the patient had a thrombus. So now question is from where the thrombus came in this patient. Maybe when we had did a dilatation of the distal part of the ostium of the LED, maybe some atherosclerotic plaque might have got attached to the balloon, and while withdrawing it might have got dislodged in the left main, causing the thrombus, or there might have been some thrombus in the guiding catheter which might have gone. We do not know. But luckily, after giving the patient thrombolytic, the patient stabilized, and we didn't have to worry too much. So because this patient was stable, so we didn't have to do anything in hurry or in rash. We just gave him thrombolytic, and luckily it worked for us at that point of time. So I think with this, I will stop my talk, and if any questions or anything is there, we can always discuss. Or if time is there, then I can show 1 or 2 more complications which you all can see, because very unusual complications also we had seen, which is very difficult to comprehend that something like this also can happen. One interesting complication before I close, just can I show one, Dr. Jamal?
When we'll discuss again, then it will better. Again, you can share if possible.
Sure.
Okay.
Sure,
because a lot of panelists actually,
sure.
It will better.
Okay.
Professor Chaudhary Meshkat Ahmed will continue the next.
Okay. Thank you very much, sir, for your elaborate presentation, the meat and the fact about the complication of the PCI. And you have shown on the deadly complication of the PCI, starting from dissection and the grievous thrombus. But one thing I was wondering, that using antithrombotic drug has solved the problem of thrombosis. You know, in the initial days, we didn't have the GP2B inhibitor. And a lot of cases were there when we landed with thrombosis, and those patients did succumb into the death. But at that time, we didn't have the idea of giving intracoronary thrombus. That is what wondering me. Thank you very much for your excellent presentation. We have, as a panelist among us, Dr. Dhiman Boni, Dr. Professor Taufik, and Dr. Khalikuzaman. We are very happy to have them as panelists among us. We have two more presenters who will present their cases, and thereafter we'll have discussion from our learned panelists. And of course, if time permits and if we are really happy, we'll be again eager to see your slides, your presentations on some of the complication, and
Sure.
that will be in a relaxed mood probably. Thank you very much once again. Now can I call Dr. Monwarul Islam to kindly present his case in this webinar?
Thank you, sir. Respected Chairperson, Professor Sufia Rahman, Dean, Faculty of Medicine, Bangabandhu, Sheikh Mujib Medical University, Professor Sajul Krishna Banerjee, my teacher and Director, NICVD, Professor Mir Jamal Uddin, another teacher, Professor Chaudhuri Meshkat Ahmed, expert panelists, and dear participants, Assalamu alaikum. After two very rich presentations on interventional cardiology, I like to take you to the realm of clinical cardiology.
Hello.
I am going to tell you the story of
Vijay.
Lifetime experience from a patient with pyrexia of unknown origin. This is the story of a 35-year-old lady. She is the mother of only son of 6 years. She presented to us with fever, cough, and shortness of breath for 3 months. Initially, she was treated for enteric fever without response. Further investigations were done, including pleural fluid aspiration and analysis, which revealed exudative pleural effusion, for which she was offered category 1 anti-TB drugs. And even after 1 month, there was no response, and ultimately the treatment was discontinued. Meanwhile, an echocardiography was done at the district level hospital, actually by 2 echocardiographers with different diagnoses. One diagnosis was mitral stenosis with thrombi and vegetations, and another diagnosis was left atrial myxoma with papillary fibroelastoma. And accordingly, the patient was referred to NICVD for further evaluation and management. When we saw the patient in our unit, this was the patient. On the left side, you are just looking at the face of the patient, and the lady was having some pigmented lesions on the cheeks, and she was mildly anemic with raised temperature. Her pulse was 103 per minute, blood pressure was a bit lower, GVP was raised. Her first heart sound and the pulmonary component of the second heart sound were loud, and she was also having a mid-diastolic murmur in the mitral area. She was having features of right-sided fusion, but she did not have any organomegaly. We looked and this was the X-ray of the patient. Just leave it. There was right-sided pleural effusion. Her hemogram showed normal leukocyte count, but raised ESR 90 millimeter mercury. Blood and urine cultures and exudative pleural effusion, as I have already mentioned. When we did echocardiography at NICVD, this was the echo findings of the lady. As you are looking on the left side, the parasternal long axis view with a large myxoma, left atrial myxoma, and on the right side, to our astonishment, there are multiple echogenic masses in different chambers of the heart. Actually, this was in left atrium, another one in the left ventricle, probably attached to the mitral valve leaflets, and another one was very close to the tricuspid valve leaflets. Actually, this was within the right atrium. And this is the moving clip of the lady. So the echo diagnosis was presence of multi-chamber myxoma, most probably. Considering the nature of lesions, the patient was urgently evaluated by the surgery department and they agreed to perform emergency surgery. When emergency surgery was done, and ultimately this was sent for histopathology, and the histopathological diagnosis was multi-chamber cardiac myxoma. This could be the end of the story, but whenever we looked at the multi-chamber myxoma in a young lady, we thought of presence of some sort of extra with that lady, and accordingly we went through the literature and we were searching for any types of familial syndrome with the lady. The first degree relatives of the lady were screened with echocardiography and also by other clinical means. And whenever we performed echocardiography with the relatives, there was important finding with the only son of the lady. As I have already mentioned, then the age of the son was 6 years. And this was the echocardiography of the child, though that child did not have any symptom, he was just undergoing screening. The child was having right atrial myxoma, and that right atrial myxoma was the only myxoma with that child. This is the recorded clip of the child. A very large multilobulated myxoma in the right atrium of the child. And here, to differentiate it from a thrombus arising from the inferior vena cava, we have to prove that there is no continuity of this apparent lesion which is in close proximity to the opening of the inferior vena cava. And so this is the subcostal view. Here this is very clearly visible that there is no continuation of any lesion from the lumen of the inferior vena cava. This is RV inflow view, also showing the myxoma in the right atrium. The child also had cardiac surgery and the mass was sent for histopathology, and again the diagnosis was cardiac myxoma. So by this time, a presumptive infection turned to be a syndrome. And if we can recollect the information collected so far, we have got spotty skin pigmentation on the face of the index patient, that is the mother, and histopathologically proven cardiac myxoma with that lady, and also the similar affected lesion of her only child, that is the first degree relative. These criteria are very rich to satisfy the need for a syndrome. And what is the syndrome? That syndrome was Carney complex, one of the few types of familial myxomas. And this Carney complex actually had 3 types of important manifestations. One is cutaneous involvement in the form of pigmented lesions. Number 2, presence of myxomas, not only cardiac, maybe non-cardiac, in different parts and organs of the body. And the third important component is presence of endocrine neoplasm. But in Our Lady, endocrine neoplasm was not diagnosed at the time of evaluation. To satisfy the diagnosis of Carney complex, actually there are some criteria, major criteria, 11 criteria, and 3 supplemental criteria. If a person satisfies either 2 major criteria or 1 major criteria along with 1 supplemental criteria, the diagnosis is Carney complex. Our Lady satisfied 2 major criteria and at the same time 1 supplemental criteria. What was the 1 supplemental criterion with the complex? The criteria was affected first degree relative. So when just to diagnose Carney complex clinically, only 2 criteria are enough, but our patient actually had 3 criteria. So this was a case of Carney complex, and this is a very rare cause of multicenter myxoma and familial myxoma also. And the case was recently reported in the case report journal of the American Society of Echocardiography, known as CASE. I think this is in article in press stage, and you can see in the next issue of the journal. Thank you all for patient hearing. Thank you all.
Congratulations, Manwar. Congratulations for, we are seeing
you,
that
sir.
your paper is going to be published in a very renowned journal in the world. We are really very proud of you. And people say you are the choice of new generation. And your story was really an absorbing story. Now let me invite Dr. Abu Selim. He's an associate professor of cardiology, Bangabandhu Sheikh Mujib Medical University. Dr. Selim, will you please present your case now?
Dr. Selim? Dr. Selim? Yes.
Can you hear me?
Yes, we are hearing.
And good evening. It's a delay. It's a time of Maghrib prayer, so I will try to shorten my presentation. And after this so elaborate and healthy case presentations and complications view, my case becomes so much lighter that I have to finish it very quickly. So let's start. My case is complex PCI or complex PCI to become simple. Our aim to make the complex PCI to make it simple. But how to it? I will present today a case that is a 60 years old male. He presented to us with chest pain, CCS class 3 and breathlessness, NYC class 2 for 2 months. He is a diabetic, hypertensive and very strong family history of ischemic heart disease. That when he came to me just 1 week ago, his elder brother expired with sudden cardiac death. He has a bad family history of death of his father also with ischemic heart disease. So we go for some investigations. So ECG shows a non-specific STD change, not significant change. Echocardiography was no significant change, but ETT was strongly positive at 6.2 minutes. But one question arises: his creatinine, serum creatinine level was 2.9 milligram. So due to the chest pain, CCS grade 3, we decided to go for coronary angiography. So angiography we did to find, that is the finding of this angiogram. That's left anterior descending arterial disease is proximal part, mid and distal part also, ranging 80 to 90%. And also the diagonal one, the big diagonal one, diagonal two, both of these were diseased from his proximal part. Then left circumflex, go for left circumflex, also diseased. It is a good size vessel. Left circumflex is a big wave. The principal wave has a 80-90% stenosis, and also the distal L6. This is the left circumflex, and about come to right side coronary. Right coronary is a total occlusion immediately after its origin. And also it feels retrogradely from left system. You can see it here that it feels up to its origin, proximal part it feels. So what should be the plan for this? We decide the baseline coronary angiogram finding was triple vessel disease. We go for syntax score very high, and creatinine was 2.9. For that, we have to think again, what should be the option for him? Known coronary disease, and EGFR was below 30. So we decided not to go for angioplasty in the same setting. We decided to go discuss with the heart team. And after heart team, we discussion, there are 3 options: multivessel PCI, CABG, or optimization of medical management. But after discussion, the heart team, we decided in favor of multivessel PCI. When we decided for multivessel PCI, there are several questions comes again. The question comes, what should be the strategy? Total revascularization or partial revascularization? And then in single setting or stage PCI, as it is a case of chronic renal failure, that is a creatinine 2.9. And how many states? Budget is also a big issue. There is multiple lesions, 2 lesions in LAD, LCX bifurcation lesion, and LAD RCA total occluded. And then bifurcation lesion, which technique? If you angioplasty for left circumflex artery, which technique we should prefer? Lots of things should be considered. As a case of chronic kidney disease, we cannot use dye, radiopaque substance so much. So we have to minimize this, or we have to think it again also. And which vessel should we treat first? And preparation of patient, like as a CKD, hydration, which contrast would be suitable. So considering all the questions in mind, we prepare the patient and we prepare ourselves also how to go for this patient. It looks as not a simple cases, but we planned it properly to make these cases more simple. So hardware, we decided for like big side. Regularly, we used to 6 French guide catheter, but for these cases, we go for bifurcation lesion. We had to take 7 French guide catheter and 2 wire, 2 types, balloon, different types, inflation device. And this is the angiographic view. I skip this view. And then we do wire and we go for LED first. For LED, we dilate the lesion first with a 1 balloon, 2.5, 1.5 into 18, 2 into 15 balloon, and with stage dilatation from distal to proximal part of the left entry descending, you dilate, and then put a stent in distal part of the left entry descending artery. That was not so much complex. And then post-dilate the left cases. I just skip these slides. This is a post-dilation with high pressure, 22 atmosphere pressure. We use distally 38 millimeter stent, and then proximal part. The proximal LED, I would took another stent in proximal LED, then I reposition the stent and overlap this stent with the proximal stent size was 3 into 33 millimeter TS. We initially dilate at 18 millimeter, and we push this stent to overlap the distal stent also. Overlap the stent, and it's the final result of left anterior descending artery. That is, I think, it's a quite satisfactory result for left anterior descending artery. That's fine. Now we come for left circumflex artery. Then what? Lots of plan, but considering the morbidity of this patient as chronic renal failure, we decided to go for less contrast area, media. So we think we should go for VT stent other than to crash or medical decay crash. That will use any crash technique uses, we know, the more contrast media. So we try to avoid contrast media. You ever try to use minimum contrast media. So we use V technique. First, we dilate this both lesion with a balloon 2.5, 2 into 15, and 2 into 12, OM and left distal L6. And then after dilation, we took a stent, one same size stent, that same length is stent. One is 2.25 and one is 2.5, respectively OM, L6 and OM. And this is our final result. This is it. But after the dilatation, we tried to get final kissing. But at that time, we didn't have that in our shelf, this non-compliant balloon, two non-compliant balloon of that size. So we could not go for the final kissing. So we pull this balloon slide proximally like a pot, and we dilate this again at a high pressure, and we find the final result of this. Next. Yes, a comparison of final result. But we decided for stage PCI. So we decided to go for right circumflex artery later. But after we planned for 2 weeks later. After 2-3 days, we discharged this patient. But if the patient becomes symptom free, he did not allow he did not agree for go for angioplasty for right coronary. So that we have to stop over there. We just repair partial revascularization by LED and L6. So my take-home message is very simple. The proper planning of a complex case PCI can make the procedure simple and uneventful. So my case is not so much complex, but by proper thinking and proper planning makes my case is more easier for the patient and for us also. Thank you for your nice day. Thank you.
Thank you, Dr. Selim. Not only you made your case simple, but your presentation has also been very simple and very well palatable. And we are very proud to see that you have done such a wonderful job and you have presented it so nicely. So we are at the end of our all the talks, and we'll now meet our panelists. Before that, we have few questions. probably will go for the answer to those questions. The first question is to Professor Mir Jamaluddin. It was from Dr. Muhammad Abdul Malik. He had the query about your last case, whether the V-stent or SKS was deployed.
Thank you. It was done SKS. Approximately both the stent are inside the left main, as because the dia of the left main could accommodate both the stents, and that is why it was done SKS, simultaneous kissing stenting. And V stent, then we keep the stents at the carina, not above the carina. Here we pull back the stents, both the stents proximal to the carina, and so it is SKS. But nowadays we are not at all doing it, and it is not at all a good technique for doing the angioplasty.
The second person who asked question was on if PCI is done only at LM to LED, what are the chances of occluding the LCX?
Very good question, but answer is very long, which I escaped. That is why you have asked. So you are congratulated. It depends.
At the same, just a minute. He also has a question. If it happens, what are the measures that can we take? So you can give answer to question altogether.
Okay, thank you, Professor Chaudhary Mishkat Ahmed. His question, answer to his question will depend on the anatomy of the distal left main with the left interdescending coronary artery and left circumflex coronary artery. Ostium of the left circumflex coronary artery, whether diseased or not. The size of the left circumflex, whether less than 2.5 millimeter or not. The lesion of the left circumflex is more than 5 to 10 millimeter extending from the ostium or not. If this is yes, that is lesion is beyond the 5 millimeter to 10 millimeter from the ostium, the left circumflex, and a good sized left circumflex and good area of supply, then we shall have to choose two stent and we shall have to go bifurcation, double stent strategy, and in that case we should not do usually single stent strategy or crossover strategy, crossover stenting. But if the vessel is less than 2.5 millimeter or disease is only in the ostium, not beyond the ostium, then we can do crossover stenting. In that case, initially all the cases, whether it is ostial or mid or distal, we should keep two wire in the one in LED and another in the left circumflex, and we should recross the wire and we should see whether there is STEMI 3 flow is there, whether there is ostial significant narrowing or not. If there is significant narrowing in the ostium or if there is STEMI flow is impaired, then re-enter into the left circumflex with balloon and post-dilatation with kissing balloon inflation with LM to LED, and final port should be done. But if this dilatation of the left circumflex causes dissection, then we should have to put another stent, and which should be usually tap fashion. Usually in the tap way we do angioplasty. And if the angle, regarding the distal angle, angle between the LED and LCX, if the angle is less than 70 degree, we prefer crash or culotte. And if the angle between the LED and LCX more than 70 degree, we usually advise T stenting or cap procedure. And if the angle is less than 70 degree, we also prefer TK crash. These are the tactics of left main PCI, and how you will treat left circumflex, that depends on these factors, and accordingly you will.
Thank you very much. That is what we had in the question box. Now we'll turn to our panel of experts. Today,
Mr. Bhai, can I ask some questions?
Sure.
Mr. Bhai, can I ask Dr. Bharat some questions? Dr. Bharat, would you be able to answer some questions?
Sure, you're welcome.
Excellent, Dr. Bharat. All the complication cases are excellent. Fantastic cases. It's learning cases as well. Just have some query regarding your first case, which was actually a RCA perforation. So you inject some glue, I believe, that blocked the perforation. But by any good time, did you able to re-look the angiogram again? Did the angiogram again to see what happened to coronary artery? Was it totally occluded, or it still has the TME3 flow, or anything? Any chance later? Did you get any chance later to see the coronary anatomy?
Yes, that point of time when we injected the glue, the glue had completely formed a thrombus in the proximal part of the RCA, and the RCA got completely closed.
Right.
And once the artery is completely closed, there is no reason why the artery will open up again, because there is no distal flow happening in this patient. And we found that the patient is having good collateral from the. It's not a good collateral, but there was some collateral going from the left side, and the ejection fraction was maintained. So subsequently, when the patient came for follow-up, the patient did not have major issue. Yes, of course, he had class 2 angina when he was doing too much of work, then he was having some angina. That he was managing. So when there was no aggravation of angina, we did not do any check angio later on.
Okay, good. So about my second question regarding the dissection, left mid dissection, did you require any hemodynamic support for this patient after the dissection? In a balloon pump or some other device?
We did not use any hemodynamic support at that point of time, because my focus was
blood pressure?
I fully understand, because there is a lot of debate about use of IABP and all this thing. Of course, if you can use all those things, it will definitely help this patient. But at that point of time, when I was doing the procedure, my focus was on restoring the circumflex, because if the circumflex closed at that point of time, patient would have crashed on the table itself. So immediately my first priority was, when I went to groin, instead of putting a IABP, which would have taken more time to arrange the IABP, connect and all this thing, definitely it take at least 4 to 5 minutes. The moment I was able to hook the guiding, the first thing I did was cross the circumflex. And if you see, the moment I crossed the circumflex, the flow in the LED was not deteriorating any further. The blood pressure was still hovering around 80, 70, like that, not going down. And the entire crossing of the LED, I don't think it would have taken me more than 4 to 5 minutes, because I just crossed the wire, and then I took second wire into the diagonal and took a microcatheter. Because when I was taking the second grade, I had already decided that I'm going to inject with the microcatheter. So I took a microcatheter, took the wire into the diagonal, injected, and I withdrew that microcatheter, and the same wire I manipulated back into the LED, and then once the microcatheter, I injected through the microcatheter and found it's in the distal lumen, and I just did stent. So it all happened so quickly that I did not. The moment I deployed the stent in LED and left main patient,
blood pressure improved.
So
fantastic. Yeah.
As I said, during this complication, the mind works pretty fast, and your hands, everything will be fast, and you go by your instincts. At that point of time, honestly, I did not think of the IABP. My first priority was to put it back, and because I didn't want to waste more time in IABP. But of course, if you have more number of hands, then you can always ask your associate to prepare the other groin and start putting the IABP in the. It's an excellent suggestion that if you are there and you have an associated with you, because it was straightforward, simple angiography. I was doing single-handedly alone. My associate, nobody was there at that time.
Okay.
So if you have an associated
at that time, yeah, that's the bottom line. Yeah. About the third case, thank you very much. It came out nicely, of course. About the third case, he used thrombolytic therapy in coronary. Yes. Normally, even conventionally, we use glycoprotein 2B3 inhibitors in situation like that, Rio Pro, whatever, even integral.
Rio Pro, Reptic.
But it worked anyway. Yeah, definitely worked. But
people have used these catheters, and then they have infused the antiplatelets for a longer period of time also. But we used, I think, tenecteplase, we used around 20 mg, I think we used in this patient. And after 5 minutes, when we checked, we found that everything is cleared off. The reason why it worked is because the patient was hemodynamically stable. and he was giving us more time. So we were discussing whether to give thrombolytic, whether to give antiplatelet. We just went with the thrombolytic and it worked. That's all.
It was
Thank you very much.
Because, but in other places, people in different situations, when you look into the literature, a lot of people have used eptifibatide also. A lot of people have used Riopri also. But nowadays, Riopri, we are not using it. We go by this small molecule therapy-1 and eptifibatide. So people do use it, and whatever succeeds, it succeeds. That's all. That's the bottom line.
Yes, after all, at end of the day, you came out nicely. That's bottom line. Thank you very much. Dr. Mona, excellent presentation from my side. I can say it's something I learned today from you, this new case, this is Selim syndrome. And I must congratulate for this paper, Dr. Mona. And I'd like to ask Dr. Selim, I mean, your case is good, but with the creatine 2.9, it still looks high to start an angiogram. I mean, a complication, unless it's dire necessary, we don't do angiogram with creatine of 2.9. But then again, you did well. My suggestion is that you could have done, if you have IVUS, of course, in your lab, if you could have done IVUS and avoid some contrast injection during the procedure as well. You did nicely, but to cut down your contrast, you can use IVUS and put the stent there. Could have been done there that way as well.
Thank you. IVUS, but in our lab we don't have so much facility.
IVUS.
To use an IVUS still now. I know that zero contrast angioplasty by helping of IVUS, but unfortunately we do not have. Thank you.
Yes, Professor Jamal.
Just one thing I'll just add here regarding the management of thrombus.
Selim, for your nice case. In that case, regarding creatine in 2.9, to me, I think it is not at all a contraindication. We are doing 3, 3.5, 3.2, 3.3, and with adequate hydration and using minimum dye, there is no problem. Otherwise, if the creatine is very high and patient is on dialysis, that is a different issue that we can do very easily. But in this case, 2.5, 2.9 is, I think it's not a contraindication, and we are doing with good results, but not impairing the LV function. And regarding VisiPeg, it is not nowadays telling that superior to
Omnipeg, VisiPeg, no big difference. Hydration is the main thing.
Almost. Hydration is the main thing. Hydration is the main thing.
Yes, we are
Dr. Bharat, Dr. Bharat, I like to know from you which wire you have used first. Dr. Bharat?
In which case you were asking?
First case, which wire you used first?
That was a Shinobi Plus wire.
Shinobi 2 Plus, at the beginning of a CTU, will you decide
No. I think you got me wrong. See, when we did that CTO, that was, I think, long by, I think 2007, 2008, we had done it. At that time, we didn't have too many wires to, initially we tried with a Galio wire with a little balloon support. I did not show all those runs there. The Galio wire with the balloon support, it did not cross at all anything. So subsequently, we just straight away changed from Galio to straight to Shinobi Plus wire.
That's right. And you have not done puncture from another groin or another arm?
No.
Seeing
we had done from the femoral only, but there was no contralateral shot was not taken.
So it is wise to do a contralateral injection. Yes. Next question, or to know proximal perforation of a big vessel, main vessel like RCA, like LED, like LCX, having good supply, large area of viable myocardium, whether should we use your glue or not? Why not using covered stent?
Yes, covered stent was also an option there, but we had already deployed one stent there, and where would have been the landing jewel of this covered stent distally, because we were not sure whether we had gone through the true lumen to the distal part. So if you see in that angio, the whole thing has happened because probably the wire had gone from true to false, and the distal part of the vessel had completely ruptured at that point of time. So if if I try to put a cover stent, we were not very confident that the wire which has gone, whether it was in true or false. So when that confusion happened, so we decided, okay, anyway, it was from the beginning itself, the proximal RCA was completely occluded. So let us bring it back to the same stage before we had started. And we had already opened one CQ at that point of time, which would have definitely given him much relief. And it was almost like a co-dominant artery in both circumflex and RCA. And with that idea only, we thought of closing off the RCA once again rather than trying to protect it at that point of time. And if we see the data also, it was hardly a 2.25 or 2.5 to put a cover stent of such a small size. That again would have caused more restenosis and
thrombosis.
Yeah, thrombosis.
Thank you for your all the three cases, and to moderator Professor Chaudhary Mishkat Ahmed, as well as the president of Bangladesh Cardiovascular Research Foundation. I beg pardon for relieving me, as because I have another webinar. Thank you. Assalamu alaikum.
Thank you for being with us. Thank you, sir.
Thank you, sir.
We have probably Professor Azam with us now. At 3 o'clock, Professor Zaman, when you called me and to ask me to conduct the session, since Dr. Dipol was sick, I had a little attraction for this program because of the panelists. It is said in the army that every general has got a style. And now, as a panelist, we have the stylish interventionalists of the country. Each of them has their own style. I want to turn to Professor Badiuzzzaman, who works in the premier hospital heart center of the whole Asia. He is a leader in National Foundation. It will be my great pleasure to invite you to say something today. Professor Badiuzzzaman.
Thank you, Dr. Mishkat, for your kind words. Actually, I enjoyed all the lectures. Both the lecture was very wonderful. Regarding the LM PCI, he has covered almost all the topics. I have just a few words to add. First of all, for the beginners, whenever you want to plan an LM PCI, you should plan earlier, whether you want to go for an upfront double stent strategy or you want to go for a provisional strategy. And always you should plan the technique you want to go, whether it's DK crush or Culotte or whatever you want to do. So don't plan it while you are doing it. Plan it before you want to start the procedure. That's very important regarding left main, because it will not give you time to decide sometimes, as you have seen the dissection in the Dr. Bharat's case. Number two, regarding the ostial left main. Regarding the ostial left main, if you want to stent the ostial left main, please always, sometimes you see the guide catheter cause dampening of the pressure. So it is better to take a side hole, or you made yourself a side hole. That will give you time and make the pressure easier, the procedure easier. And what I do always while doing ostial left main, I always must find out the appropriate view, which view the ostium is most clearly defined. It is not always the same view. Sometimes, usually it's left iliocranial view, but it is not always the iliocranial view. So you first off, you have to see which view you can see the ostia clearly, so that you can, while putting the stent, you cannot, you should surely cover the whole ostia. So that's very important. So it was a wonderful talk from Dr. Mir Jamaluddin, Professor Mir Jamaluddin. Regarding the second, regarding the complication of Bharat, excellent presentation of Bharat. We have tackled all the complications very nicely, and as you have said, a complication happens. It never, it should be very cool while tackling. It should be very cool, be very quiet, but very sweet. And so I think all the complication case you have tackled very nicely. I enjoyed all the topics. Regarding the right coronary artery, I think that was the only option left to totally block it. Just one question, one query. Could we have used a 3 millimeter or 4 millimeter coil to block it instead of the gel? Because gel, get the gel and prepare it, and it may not be available in everywhere. So coiling could be a choice of blocking, because it was already secure. So blocking it totally will not going to make any difference for the patient. So I think blocking with the coil would be a better choice. Otherwise, it was a great presentation, Dr. Bharat. And regarding the presentation, I just missed the presentation of Monwarul Islam. I went for Maghrib. But anyway, I will later on catch with you. And regarding the presentation of Selim, as Dr. Tamjid has said, 2.9 creatinine is not an contraindication. If the patient has a compelling indication, patient has class 3, class 4 angina, not relieved by maximum medical medication, then you have to go for PCI or whatever it might be. What we do personally, we always consult with the nephrologist that your patient is having class 3 or class 4 angina, not relieved by maximum medication. We want to go for an angiogram, which may lead to AKI. So you must be prepared to tackle with that. So that nephrologist give us the clean check. Okay, you go for it. Later we go for it, and we go. And adequate hydration, with adequate hydration preparation, usually we don't have that much of problem. But patients who are already on dialysis, we don't have any problem. We have done a lot of cases with creatinine 7, 8, 9, 10, because they are on dialysis. So when we do the case, they go for the dialysis. So it doesn't make any difference. So thank you for inviting me to this wonderful webinar, and hope to see you again. Thank you very much.
Thank you so much. I'll now ask Professor Kabir. He is Professor and Head of the Department of Cardiology, Chittagong Medical College. Sir, will you please make some comment?
Thank you, sir. You're my course mate. You remember me. Very nice moderation. First of all, thanks a lot for the nice moderation. Very impressive moderation by Professor Chaudhary Mashkat. Thanks to the presenters, 4 presenters presenting such wonderful cases, especially Dr. Bharat from Hyderabad. So you used lighting material as well as sealing material. So 2 cases producing 2 diametrically opposite material to control the complication of PCI is really amazing. Thank you very much. And Dr. Monwarul has presented a wonderful case, what we read actually during our student life, Canary syndrome, autosomal dominant. This is a nice case. So it's a great learning from Monwarul today. And our first presenter possibly left for another webinar. The left vein lesion, which was an area of our fellow surgeons, the area has been captured by people like us, our fellows interventionists. So possibly we should leave at least some of the cases for our fellow surgeons, especially those which seems to be very complicated, distal lesions, osteal lesions. And regarding our center, we are running 2 cath lab in our medical college, but we are lacking facilities of IVUS, FFR. So regarding left band lesions in our center, only the mid LAD lesions, mid left band stem lesion, we prefer to do it, but we leave the most of the osteal and bifurcated lesions for our fellow surgeons. So we have also cardiac surgery department in our center, Chittagong Medical College. And this again a favorite place for our intervention because of the larger caliber and very easy to negotiate with all guide wires and balloons and other devices. So with these few words, again, thanks to our presenters, learned presenters, our panelists, especially my teacher, Professor Sufia Rahman, and very nice to see all striking interventionists, and thanks to the organizer to invite me. Thank you.
Thank you very much, sir. Professor Tamzid, do you have anything more to comment? Professor Tamzid.
Professor Esar Khan here.
Okay, now we can turn to Professor Esar Khan.
Sorry, Mr. Bhai, I just finished my prayers anyway. Did you ask me something?
Yeah. Do you want to add anything, or do you want to compliment anything?
Oh yes, of course. I missed Jamal Bhai's lecture. Part of the lecture, but it's excellent. Yeah. In fact, regarding SKs, it's right. I think sometime I have done cases SKs before, but it has become nowadays sort of obsolete. You know, as Dr. Jamal, because it's you have to two stents parallelly placing in the left main. It's a question of sometimes after restenosis or anything, and it end up with a problem. So it's better to avoid this case if possible.
Then
and hello,
we can hear you. We can hear you.
Yeah, of course. But the rest of the procedure, I mean, all the procedures are excellent, as described by Dr. Professor Jamal Uddin. I think he's still in prayers, I believe. I can't see him right now.
He's a different webinar. Thank you very much, sir.
Thank you very much.
Now, can I invite Dr. Professor Sayur to say something as regard all the presentations, and if he has something to comment upon.
Thank you, Dr. Mishra. I think you are hearing me clearly?
Yes.
Clear and loud, yes.
Okay. Just talking about or hearing about left main and complication in PCI. It's just like walking in Amazon. So all the time, you will be in a maze or somewhere, because whenever the complication will come or from which angle the complication will come, nobody knows, even for a high volume operator. So this is pretty natural. So how you will handle these things, even for every case and for every operator at that very moment, is totally different. And to learn from that or to hear from that is sometimes it's really confusing sometimes. Like this way you will handle and some way that person will handle. So that's the way, like in my case, so the dissection has caused the left system totally occluded. And at that time, you have nothing to do. Patient is in sepia and you are putting the wire, just putting the wire there blindly and doing a stenting with a bare metal stent so that at least whether it can make her survive a little bit, though we don't have any chance, but it happened. And the patient survived and now is surviving for the last 2 years. So these are the things, the complications and how to meet the only thing is that how you or every intervention cardiologist will have to plan from before so that the complication doesn't happen, because every simple case is not simple at any cost. And for left main, what I can say to whatever Dr. Jamal has told, that these are now, that is the craze of the world in the intervention to deal with the left main. Still, Excel trial, which we refer or prefer to go for left main. This Excel trial has got controversy now. So still this is a 2A in some cases and 2B or 3 indication for left main, especially for distal left main true bifurcation cases. So still CABG is the preferred option in that case. So in these sort of cases, I'm a little bit skeptical until and unless the indication, and at that time, the patient's contraindication for CABG is the most important factor we have to keep in our mind. Rather than just doing a left main is very easy, but that a small opposition for left main is pretty dangerous in the long run. But otherwise, in the mid LRD, RCA, wherever it is, wherever you put a stent, it doesn't matter with the malopposition. So image-guided left main, if you have that imaging options like OCT or IVUS, we should not touch the left main until unless we have that capacity or we have that hardware, that adversaries in our docket. So that's the most important thing I can tell. And for the cases, I think that I am just, Dr. Tamzid was in our hospital before. So, that in our hospital, the CKD or whatever this is, stage 4, type 4, that is the EGFR is 30 to 45, there are lots of cases we have. So in these cases, 2.9 or 3.5, even 4.7 is not a problem, what Dr. Badizaman is telling. But my concern is there, which I want to say, that whether at that time, or maybe just 3 days back, the creatinine was 1.5, and after 3 days, it has been 2.9 because of some worsening ejection fraction or because of some non-ischemic or whatever it is. In that case, we have to be very much cautious to go for this sort of PCIs or other things before stabilizing the kidney level to heal the kidney or to give the kidney a little rest, because otherwise 2.9, 3.5, it is a chronic kidney disease that is almost running in between 2 to 3 or 3 to 4. Then it's not a big deal to do that one. And adequate hydration, because you know that sometimes the ejection fraction is too low, pretty low. In that case, adequate hydration is all the time is not possible. So, but still, just minimizing the contrast by 5 French guide catheter and using the radial approach sometimes then can help you. That's all I can say. Thank you very much.
Thank you. Thank you very much. You know why I became quasi-interventionist? Because many of the interventionists used to refuse the cases having chronic renal failure. Since we work in a multidiscipline hospital, we have the courage of doing those patients, whatever may be the serum creatinine level. But to my experience, seldom this patient really do deteriorate and do really require the dialysis.
Yeah, Dr. Meshka, Dr. Meshka, the only thing is that please don't send, doing a PCI, please don't send a patient for hemodialysis, which we don't want. That's one is the most important thing to do, that not to send the patient at least for hemodialysis. And keeping all the facts, like all the risk factors, all the present conditions, if it is in favor, then it's not going for a hemodialysis. And that's a great favor for the patient, because a patient after doing PCI, you are fixing the heart, but ultimately the patient is going to hemodialysis, and maybe it may turn into a maintenance hemodialysis. That's painful.
I got your point, but I had some hard reality. All the patients we had for dialysis is from private sectors, because people went there, had their PCI done, and they didn't have the money to give to the dialysis guy. But same thing do not occur in BSMMU. Here we are in a multidiscipline hospital, and we cannot remember any of our case. We had to refer to the dialysis. And of course, you are very right about the complication that can occur with any patient. And in old days, saying was that mid RCA discrete lesion, you have started the lesion early in the morning of Monday, but still you can have a very bad day. It is very known old saying. So smart and stylish cardiologist begets another stylish and smart cardiologist. May I now invite Dr. Azam, Professor Azam, my very favorite cardiologist, interventionist. Will you please be with us, and will you please delight us? Azam, are you there?
Azam is not here, I think.
Azam is not here. Dr. Mahabur Rahman is here or not?
Yes, if Azam is absent, I have got another option, equally favorite. He's a poetic man. He's a stylish cardiologist, and seldom we can find them in this occasion. Today we are very fortunate to have the cardiologists, interventionists. They're really doing so good job in their own field, and really do we have the opportunity to meet them. It is our great opportunity to call now Dr. Mahbubur Rahman. Mahbub?
Sir, he is not with us.
Mahbub is also left.
Already he's left, maybe.
Yeah.
Jamal, will you call some?
Actually, I will say something. Then Professor Sufia Rahman finally actually conclude.
Do you want to hear from other panelists?
Actually,
most of them are left. Actually,
most of them has left, maybe, because there was they told me, yeah. So
okay, now then we can turn to Professor, our chairman, madam.
Okay.
Professor Sufia Rahman to conclude the session, right?
Yeah.
Okay, Professor Sufia Rahman.
Madam.
Well, there is another program, I think, for 8 o'clock. It's quite. It's not even 8 o'clock. Anyway, for me, thank you to the organizers, Professor Meshkat and Professor Zaman and Shazal Banerjee. All of you from BSMMU have given me the opportunity to be with you. and it's a great day for me to have my all favorite students in the panel and also presenting. And I've seen a rare, okay, I start from the last to come to the first. Like my last presenter has shown is very nicely, is discussed already. I don't want to go detail in it, but I'm impressed that what you people are doing, and really impressed. And also today I've seen these Carney syndrome, which I've never seen, and it was really nice to see, and it's recapitulating what we studied in the book. Thank you for that, and it is really excellent case, and congratulations for that. And from India, Dr. Bharat's complication is easy. You see, complication when we started, let me go back. We used to have every day the dye reaction every day in the voting. There's no doubt about it. We used to have a dye test. Even then, we used to have a complication. That was a compulsory thing there. And then when we even diagnostic, there's no harm in admitting at those time, even in India, even in Singapore, they used to reuse the thing. So when you reuse the thing, there was a complication is much easier or earlier, or it can happen anytime, whichever way you want to say it. So I remember my complications when I used to have. You people are so lucky that you have got people around you to share or even to ask. When we started, we didn't even have a telephone to discuss with anybody. It has to go through the landline. And you can imagine, you cannot get a landline with anybody in the abroad. So first I had my nightmare when I did diagnostic, and I found that there's a spiral dissection of right coronary right from the ostia to the end, and I didn't know what to do. Honestly, I didn't know what to do. Then what we thought, I said, okay, let's wait and see how the patient reacts, how he responds. We waited for half an hour, then we waited for 45 minutes, and nothing happened. No angina, no drop of blood pressure, and no arrhythmia. So then we quietly got him back to CCU. And that day I stayed in the hospital all night because I was not comfortable that it happened. But it can happen. There's no case in life you can say that this is a simple case. A simple case can turn out to be so complicated you can even imagine it. When I started this left main, I totally agree that if you have to do the left main, you have to plan. You have to plan how you are going to tackle it. See the left main size, see the both LAD and circumflex, and then decide which procedure is the best for you. When I had my problem, let me tell you, because I probably will not be there tomorrow, means in future, to tell you that my left mains were mostly in National Heart Foundation when I developed that center, and that was all rescue, not planned, rescue PTCA. So that time I didn't have anybody with me to say, but my all fellows are there supporting me morally and practically. And I remember first 10 cases rescue I did in, all of them were in National Heart Foundation. Ultimately we followed them. And at that time, do you know, we didn't have even a drug-eluting stent. We had no choice than to wear the BMS. I followed them up, and luckily, those are all okay. Some of, about 3 of them subsequently went for bypass because they had other lesions as well. So this is my experience there. And we did primary PCI in NICVD, you all know that. But due to the support, lack of support, I should say, lack of support, lack of encouragement, lack of manpower is not all. You need the technical support as well, which we didn't have. So then we decided not to play with people's life. It's better to be safe than to be sorry. And all the cases in our time, left main you have diagnosed, and it has to be surgery. At that time, even worldwide, there was no left main intervention at that time. So whatever you find, if the patient is stable somehow, and then you refer to the surgeons, and then surgeons will say, oh, take the dispirin off, take those off, these off, 1 month, this is just had MI, so you have to wait 1 month or 6 weeks, and like this, that they used to delay, and then ultimately patient had a surgery. These are my days, what I'm talking about. You're in much better boat now to do all these things. You've got FFR, IVUS, you've got OCT, everything. So those days, we never even dreamt of doing the main stem PCI, because it was even not our teachers were doing abroad, and in America or in England, or in the whole Europe. So but what we did is that when we need to rescue the patient, we did that, and patient was followed up by followingly by surgeon to make a complete revascularization. Our time also there was a problem as well. We had bare metal stent. You used to inflate, and then you cannot deflate the balloon, and you are stuck with that. What to do? We didn't know. Then you think of yourself. You become Einstein yourself. There, you ask your juniors, you ask everybody what to do, and that we had that sort of a problem as well. So gradually we came to know what to do, and these problems these days are much less. Then when we used to crimp the stents in the beginning, that would be mainly JJ stent, and hardly they were lost actually in the system. But those are already come up with the balloon mounted. Some of them used to have a problem, either technical problem, or there was a calcification in the coronary which you couldn't see, and then the stent would have been dislodged. And you all know all these, what to do these days. And at that time, we didn't have anybody to tell. We used to do ourselves, whatever we thought good. And then I used to take my CNET film. Now it is a CD you can do, but we did a 36 millimeter CNET film. I used to carry to US or even Europe to show them that this is what happened, and I did. So for my first 10 cases, I took it and showed them there. They said, it's fantastic. You've been very good, encouraging me actually, saying that is the way you rescue the patient and then refer the patient for the further full revascularization. Perforation, as you said, it is a common thing. We didn't have even covered stent when we started. First when we started, there was no stent, and then when we stent came, there was no covered stent. But the other procedures, that you inflate the balloon there, then you reverse the heparin, and all these things you do. And even then, if you are not anywhere, then you call the surgeons to find out where it is. But it was hardly done in our country at that time. So that was the days when you can imagine, can you see yourself, and if you are there and you don't have anybody in front of you or in your back to solve your problems. But these days, I'm so glad to see so many things are there, much easy. That's why I'm saying that you plan, because you've got everything in your hand. We didn't have an IABP even. So now if you want to do it, you're most welcome to do it, but make sure and plan it. If you're not sure, ask your colleague. Not sure, support or discuss what will be the best for this patient, which technique I should do, what size I will take, and then IVUS will guide you, OCT will guide you, and then FFR is there if you need to know what to do. So these things are, make use of it, and then you will be in a better boat and you'll have a less complication in your life. There is no doubt about it. The one tips I will tell, the seniors all know you are working, you are doing very good job, and I'm proud of you, all of you. But those are some students who are there, or juniors, those who are listening. When you are doing any PCI, any procedure, keep an eye and two things there. Overall, you are looking after the patient, not our. Look at your tip of the guide, where it is sitting, and look at your tip of the where it is going. So when you decided to dilate, make sure you're where, just have a quick look, where is the tip, where is the guide, and then do a balloon dilatation, and then after that you can put the stent even, no problem. Then in this way you can dissection by the guide and the perforation by the wire. All this can be avoided as well. Two things, make a habit of it to see that you see the tip of the guide and also the tip of the wire. Make sure these two things are what you want, the way you want is there, and that's the best to avoid most of the complication. And the balloon, I know there are in these days a lot of good balloons have come up and you can do it, and you're doing very good job, there's no doubt about it. So my advice is that those who are planning for the main stem, please just make you must have your dedication, but make sure and see what you want to do and then do it, and I'm sure you will not have much problem. The presenter of also the first presenter, Professor Jamal, was also my student. He has presented nicely. Probably for the lack of time, he has cut short a lot of it. I'm not going, the presentation was good. All of them has presented today very nicely, highlighted the thing. But all of you who are going to do this work, please make sure that you must think of the patient safety first. And then what you're going to do, if you think that this case is going to have a more complication or have a complication or is very difficult, please don't do it, and you can send it to the surgeon. Especially those people are having diabetes and not controlled patient, you know how your patient is. These are better to have a surgery than to have a PCI. I'm sure you'll agree with that. And this should be the norm, that we should think if the patient's compliance is not that good, then please don't do it, intervention, send it to the surgeon. That's my advice. And thank you all of you to have me today with all of you, and please keep doing work. Thank you, Meshkat, and Shajal Banerjee also left, I think, and Dr. Zaman also.
No, so I'm here.
Keep up with the very good work. I'm sure you'll do it. And thank you again having me.
Thank you, madam. Thank you, madam, for your actually nice experience you have shared with us, and especially your advice will follow every time. And because after the actually chairperson space, just I will conclude with the permission of the chairperson. Especially I must thanks to our presenter and speakers, especially Professor Mir Jamaluddin and Professor Dr. Bharat Purohit. Actually, again, you have enlightened us, and our two presenter, Dr. Monwarul, actually I'm amazed with his presentation, especially already Professor Sufia Rahman already mentioned. Really, first time I've heard and I've seen, and I hope you will go a long way. This is my actually experience from my little, though all are students of our Professor Sufia Rahman here everywhere. So Professor Dr. Selim, again, thanks to you and our learned panelists. We have learned from many things from our panelists. Actually, again, I must thanks to them. And I hope again we'll meet again through this webinar, and with the permission of the chairperson, I will conclude this session here.
Thank you.
Thank you.
Thank you very much.
Thank you. It was excellent. And you made my day. I have read it, but I never seen it.
Madam,
থ্যাংক ইউ। প্রেজেন্টেশন সবই ভালো হয়েছে আসলে। মনোয়ার, তোমার এটা দেখে আসলে
পরে দেখতে হবে, আমি তো নামাজে গেছিলাম।
হ্যাঁ, আমিও আসলে এক ফাঁকে নামাজে গেছি, একটু মানে মিস করেছি কিছু না কিছু সবারই, মানে ইয়েটা আমি একটু সেলিমেটটা মিস করছি, মনোয়ারটা দেখে গেছিলাম, মনোয়ারটা দেখে সেলিমেটটা সময় মিস করছি।
পাবলিশ করার মতো
ওয়ার্ল্ড ক্লাস একদম ম্যাডাম, তাই না ম্যাডাম?
Thank you.
Dr. Bharat, thank you again.
Thank you, Dr. Jamal. Yeah. Thank you, Professor Sufia. Yeah. It was an honor to be amongst such great intervention cardiologists of Bangladesh. I really felt amazing and listening, especially the Cardiovascular syndrome. It was really great. I never had seen such a case. We had seen so many LM but that was an amazing case. Thank you for inviting me and be a part of a wonderful webinar. We hope to be seeing each other again in near future. Thank you once again.
Thank you, Sir Khan, again, because you have joined. Already I'm saying, Professor Sadur Rahman, thank you. Already meeting is finished. Just meeting is finished because just.
Thank you.
And Jamal, thank you. Thank you very much.
Thank you.
Thank you so much, sir. With your kind permission, I just want to close today's webinar. Hope to see you next Thursday, sir.
Thank you.
Thank you so much. Assalamu alaikum.
Walaikum salam rahmatullah.
Walaikum salam rahmatullah.